Introduction to Nursing Concepts, Nursing Process, Part 3. When we develop a nursing diagnosis, we need to think of the client needs and put those in priority. An actual nursing diagnosis is a three-part, and it has those three parts because it's a problem that they have now. A potential or risk then is a nursing diagnosis where we are planning or thinking ahead that they are at risk for some nursing or health problem, and we can do nursing interventions to help. We also have wellness and syndrome nursing diagnosis. When we think about a man with chest pain, the nurse would assess and identify things that he has related to that over the medical diagnosis of possible MI. So our actual nursing diagnosis has these three parts. This is good to know. Our P stands for the problem statement. The E is etiology, or what's related to it, and then the signs and symptoms are very specific for that patient, and that's where we get those from doing an assessment. An example would be pain related to surgery for a gallbladder removal or a cholecystectomy, as evidenced by wincing, abdominal guarding, and stating a pain of 5 out of 10. With that actual nursing diagnosis then, our NANDA label comes from the book, and that's our problem, and that's always written exactly like it is in the book. The related to, we have to ask ourselves, what are the contributing factors that go with that? And that ideas are in the book in italicized, and then the evidence will not be found in the book. This is from your assessment where you do the signs and symptoms or get cues from the patient for the defining characteristics. Our risk nursing diagnosis then is going to be two parts, and that's because the signs and symptoms are not there because they are at risk for it. They can be at risk for skin breakdown. The etiology or related to then the risk factors would be things such as the patient is very thin, the patient has possible high Braden scale, so there is no signs and symptoms noted as of yet. How we use the nursing NANDA book then, I will be going over that with you in class because it has 3 sections and you have to be able to find the key or bolded words to be able to pull it together. So when you bring your book to class, we will be going over how the nursing diagnosis book actually works so you can find what you need to. When we use a nursing diagnosis book then, these are some terms you need to understand. The label definition is the conclusions that are listed as a nursing diagnosis. They describe or define the problem. Our defining characteristics is the data that's found that supports the label definition that we gave them. And then the related to factors, the etiology is possible issues or concerns that we have as a result of that problem. As we write the nursing diagnosis, then we need to collect the data first, compare it to what's normal and what's abnormal, put those characteristics together in a cluster as we did before, what of the characteristics fit, identify their needs and problems, then find or infer possible causes, look at our NANDA list and find one that fits the particular problem that we're looking at, compare it to the risk factors, and then we will write our nursing diagnosis statement. Things we want to avoid doing when we are looking at writing a nursing diagnosis is don't mix up the nursing diagnosis with a medical. We don't want to write pneumonia because that's a medical term. We want to write our nursing diagnosis that fits for that patient. Keep them separate. Don't put two problems into one, and don't write the statement in such a way that it legally incriminates us. Other things to avoid, remember that it's not the medical diagnosis, it's related to the client, and identify the client's response rather than the equipment itself. So how did the patient respond to the pain? How did the patient respond to the walking or the ambulation as we look at things that we want to put in there? Identify the NANDA diagnostic statement rather than the symptom they have, and then identify the problem caused by the treatment or diagnostic study. So as we look at our nursing diagnosis, we want to develop it from the data we collect. not the other way around. And we don't want to try to fit the client into a nursing diagnosis because it sounds like a good nursing diagnosis, but we want to make sure we look at those data that has been collected and fit it to the best nursing diagnosis, and then what is their response to that. So in our nursing process, the planning phase, we want to make sure that it's about the client. It's not the nurse will ambulate in the hall with the client. It's the client will. What are our expected outcomes? What will they be able to do by the time we set the goal for, and then plan those nursing interventions? We always want to prioritize. When I have a slide up and it has 4 or 5 nursing diagnoses, you will always want to be thinking which one is the priority, which one is the most important, remembering Maslow's hierarchy. And then rank them in the order of importance and help to anticipate which interventions are going to be needed. As we set those priorities, then we want to make sure that we are using Maslow's hierarchy, and as we look at that hierarchy of needs, we know then down here the physical survival, then comes safety, and then social or belonging, ego, and last is that self-actualization. So keeping a patient safe and breathing is really priorities for us looking at Maslow. Other things when we prioritize, what is the patient's priority? Maybe for a hospice patient it truly is pain control, and they don't care if their skin breaks down. So look at that overall treatment plan and think about what is the important part of that, and then prioritize them according to the patient. When we identify goals and outcomes, we want to make sure that we know the difference between a goal and an outcome. A goal is very broad. It helps guide our plan of care. You might have a goal of graduating with your RN degree. To have an outcome, you want to be able to say, by May of 2014, I will have completed all of my nursing classes and graduate. And that is much more specific. It's very centered on what your goals are. And so when we have client-centered goals, we want to make sure that they're individualized. We don't go in and write nursing diagnosis based on looking at, oh, this is a 65-year-old that's admitted with pneumonia. We look at that patient and what are their goals, what are their outcomes, what are the other comorbid health conditions going on at that time. So again, we have 2 types of goals. One is short-term. It's what we want to be able to help that patient achieve in less than a week. Most of the time in clinical, you will write a short-term goal because you were only there for 2 days. A long-term goal is usually weeks or months down the road, and maybe for a patient that's had a stroke, a short-term goal is that they will be able to pivot and stand with the help of a walker by the end of the week. And a long-term goal would be that they're able to walk down to the end of the hall and back to their room by the time, 2 weeks. Again, our goals then, our outcomes have to be about the client. The client will. We have to be able to measure and observe them. And measurable means that we can say they walk 50 feet. We don't want to just say they walked in the hall. We want to be able to say walk 50 feet in the hall, and they have to be clearly written. We have to be able to read that goal or that outcome and be able to know exactly what we're doing with that patient. That we walk him, with his tennis shoes, that he is ambulating with the walker or the gait belt. And then our time limited tells us that we have to have a goal, when we're going to achieve this by. And perhaps by the time that date that we determine our outcome will be met has been reached and they haven't met it, we need to extend it. They're getting stronger, they're ambulating, they ambulated 30 feet in the hall, and maybe by next week they will be ambulating by 50 feet. It has to be realistic. If you have a patient that has had a stroke, it may not be realistic that he's going to return to his former job, that he's going to run a marathon, that he's going to be able to do all these things, but we need to set it up so that the patient is able to achieve that. The functions of outcome give us some direction for our activities. They help us project our goal that's out there, and it's an opportunity then to look at what other resources or equipment might we need to help this patient to achieve the outcomes that we want. Our guidelines then to write those, we need a subject, and it's always going to be the patient or the client. Our verb is what? Action, ambulate. They will be able to list 3 different types of medications. The condition is the circumstances that they will perform that. Our criteria then is how well they are able to do that, and then our time frame. So the client will ambulate 50 feet in the hall by Tuesday, June 24th. To make our goals more specific, then you can see that the first slide has improved nutritional status. But if we put the client will gain 5 pounds by October 5th, that's much more specific. I can measure that. I can identify that, yes, they have gained 5 pounds, or that they are able to feed themselves by the end of the week, or that they will rate their pain as a 3 or less 1 hour after the medication. So when you're writing goals, you want to make them as specific as possible so we can have that goal in mind and know if we met it, partially met it, or didn't meet it at all. So when we look at measurable and non-measurable verbs, we want to think about the types of verbs that we use for performance or by target time, all of those things. Measurable verbs are verbs such as describe, demonstrate, and list. And non-measurable would be a verb such as accept. It's very hard to measure accept. The patient accepts he has cancer. You can't very well measure that. So let's practice just a little bit in the remaining minutes that we have. Client A, both of these patients are having problems sleeping. But in client A, he's got a big test and he can't relax and he's worried about his grades at school. Whereas client B takes a diuretic and he drinks too much water late at night and he has to get up at night to void. And so for both of these patients, they're not sleeping, but it's from a different reason. So our plan for client A is to help him learn some relaxation and to help him maybe exercise before bed and take a hot bath and do all of those things to help decrease his stress. Whereas client B, we're going to restrict his fluids late in the day so that he isn't getting up at night with nocturia. Our nursing intervention listed then is that action that's performed by the nurse, and it helps that client achieve their goal and their outcome by a specific date. Our interventions are directly related to things that we're going to do for actual or wellness diagnosis. And we can also look at risk factors for our 2-part at risk for nursing diagnosis. These are nurse initiated. We can initiate these independently. We don't have to get a doctor's order to start a nursing intervention because these are things in our scope of practice that we are able to do independently. Physician initiated would be where the doctor writes an order that says ambulate the patient, or low sodium diet, or give a diuretic early in the day. And then collaborating is really a great thing because we work with social workers, physical therapists, our occupational therapists, doctors. Everybody's on board to collaborate to say, what are we doing to help this patient to improve and to get stronger and to meet their goals. To select a nursing intervention then, we want to use our critical thinking so we can meet those goals and expected outcomes, and our orders then are going to list the date that the order was written, what we need to do, who's going to do it, how, when, where, how often, and then the nurse will sign that she has completed that. A nursing order, remember then, is our NANDA or NIC, and we observe the incision every 4 hours. We monitor their response to pain. A physician's order then might be to change that dressing every day, to give morphine sulfate 4 milligrams IM every 4 hours. So the doctor's orders are medications, lab tests, treatments, And the nursing interventions then are things we know we can do, such as turn the patient or monitor for pain. This ends part 3 of our nursing process. Thanks.